I'll be covering the first presentation on strictures and how to evaluate. So it's titled An Overview of Evidence and Guidelines, but actually there's not much evidence and it's mostly expert opinion, as are the guidelines that are available. So as learning objectives, it's to recognize which clinical story is suggestive for upper GI strictures, understand what the possibilities are to assess, when to use fluoroscopy during assessment, and what to do when you don't have it available, and what the different treatment modalities are, and we will delve deeper into that later. So first of all, strictures in the upper GI tract can be symptomatic or asymptomatic, benign, malignant, esophageal, most commonly, but also duodenal, that's mostly post-surgery or post-intervention, or malignant stricture, and then gastric, and then simple or complex. I think our focus of today will be the symptomatic strictures, the benign strictures, mostly esophageal, but also one pyloric, and then simple or complex. Esophageal symptoms, multiple symptoms, mostly progressive dysphagia or dysphagia on its own, and patients can also present actually with a food impaction, but if you ask them some questions, they will say that they have had progressive dysphagia over the last couple of months. This is mostly related to a stricture that is a diameter of 13 millimeters or less, and if it's above 25, then patients are usually asymptomatic. And so why is this important? Because the therapy of these strictures, whatever the cause is based upon symptom improvement, and this is mainly relieving the dysphagia, the main symptom. We can use a clinical dysphagia scoring system for this. This was originally described for palliative treatment of esophageal cancers and how to evaluate before and after treatment. But this is actually widely applicable to all types of strictures, esophageal. And so it's going from 0, no dysphagia, and being able to eat everything that they want, to 4, which is no passage at all, unable to swallow anything, and saliva coming out. So what are the causes? We always have to be mindful of a malignancy. This is mostly a esophageal cancer, but can also be external, compression by lymph nodes or an ingrowing lung cancer, but also a lot of benign disorders that can be intrinsic, esophageal, or accidental or iatrogenic. And so most commonly it's peptic. That was especially more the case in the past. Now with the use of PPI, we see that less. EOE is becoming more and more obviously a reason to have strictures. Some motility disorders like achalasia, not that common, but can be a cause of a stricture. Rings and webs, Schatzkering, but so what do we see often in this center, for example, is post-surgical, so anastomotic and after endoscopic therapy, which can be either EMR, ESD, or RFA, and then acoustic ingestion as most common reasons. For gastric and duodenal strictures, it's mostly the symptoms of that can be said for gastroparesis or a gastric outlet syndrome, and it's nausea and vomiting, and then some less sensitive or specific symptoms, I would say, like bloating and early satiety, etc. What are the causes here? It's also malignant is possible. Can either be a pyloric cancer, can be a duodenal cancer, biliopancreatic, but can also be benign conditions like an acute pancreatitis or a chronic pancreatitis, peptic ulcer disease. But also something that we see regularly here is post-surgical or post-endoscopic resection, pyloric stenosis, for example, or in the duodenum. So vagotomy after surgery, but also Crohn's disease or a large gastric polyp that obstructs the pylorus. So how are we going to assess? We always want to see endoscopy first, but actually we need to do a thorough history, medical conditions, surgery, radiotherapy, drugs that they're taking. So we have an idea of what the cause might be before we start. But the second step is an upper GI endoscopy, which is good for diagnosis and can be good for treatment. As John has mentioned already, if you are not sure about what the diagnosis is, the first step usually is not dilating, it's taking biopsies, being sure that you are not dilating a malignant stricture, for example, because this is to direct your treatment. You want to know what the cause is, but an upper GI endoscopy will also give you an idea of the location. Is it in the proximal, mid, distal esophagus? Is it pyloric? Is it duodenal? Yeah, I think that's most you can get out of the endoscopy. You can also do a barium contrast swallow for esophageal strictures. It's quite sensitive to diagnose this, and this is also when standard endoscope cannot pass and you don't have a small caliber endoscope. And you can also consider it as a first-line investigation if you suspect a complex stricture, not necessarily like a large ESD in the esophagus. You could say, we want to do this first to have an idea already, but yeah, you can also just go for the upper GI endoscopy with fluoroscopy. Then CT with oral contrast and then EOS, but those I think are used less for these strictures. So the benign esophageal strictures, we can divide them into simple and complex strictures. With most commonly simple strictures, the peptic strictures, the esophageal, the EOEs, Schatzky rings, and the complex post-endoscopic submucosal dissection, anastomotic caustic, and radiotherapy. What's the difference? The simple ones are typically short, less than 2 centimeters, are focal, are straight, and can or cannot allow passage of the endoscope, whilst the complex are typically longer, multiple, irregular, very, very narrowed, as we've seen today, and they have a higher tendency to become refractory or recurrent. What are refractory and recurrent strictures? Refractory is a stricture that over 5 therapeutic sessions, 2-week intervals, we cannot maintain a diameter where the patient is comfortable, doesn't have that much symptoms. A recurrent is that we have managed it, but this is not long lasting. It's not for 4 weeks. When are we, so next topic, when are we going to use fluoroscopy, as was asked this morning? So for benign esophageal strictures, during the assessment, a simple stricture, as we've seen, you can look past the stricture, it's not needed. With complex strictures, as the previous case, it's definitely useful to assess the length, the diameter, if there are possible fistula, etc. During or after therapy, for simple strictures, in general, not needed. For complex strictures, it's also good to have to advance guide wires, to place stents, to make sure that you haven't caused a tear or anything. What if you don't have it? You can use a thin caliber endoscope, or if you want to measure the length of the stenosis, as John has said, you can, for example, use a ERCP balloon and try to measure it indirectly in that way. What about gastric and duodenal strictures? Gastric, in general, you don't need fluoroscopy. Duodenal, it's probably useful to assess it and to check for a leak after dilation and stent placement, but also this is very case dependent. This is an overview of when to use it, when not to use it, what we think. There's not a lot of evidence to support this. I think it's what you have in your center and what you're used to using. And then a suggested treatment algorithm that we will go through the different types today for esophageal, benign esophageal strictures. Also, this is more eminence-based than it is evidence-based. So step 1 is dilating either with balloon or with bushis. Step 2 is going to a dilatation and then steroid injection or incisional therapy. If that doesn't work, you can choose for a stent placement, and if that doesn't work, if there's an option for a self-dilation, then that is also a possibility if you have it available. And then very last step is surgery, which you would like to avoid in every case, of course. But if there's no other option, then that is the last step. And as I said, the different modalities that we will also use today is the steroid injection. Is there all of these options can be used in most esophageal strictures. This also differs depending on the etiology, because, for example, EOE, you don't just want to go dilating, you want to treat the underlying EOE. It's all dependent on the etiology, but for most of these treatments, there's not a lot of evidence to support which one is better. So it's, as said, what you're used to and what you've been taught to do.